Thank you all for joining this fourth and final session in the Division for Research Development's Research Integrity and Ethics Info series. So today we will focus on the ethical considerations and processes for human research, presenting to you Stellenbosch University's approach to research ethics for human research in the health sciences as well as the social sciences. So I'm honored to open the session and introduce my colleagues to you. We have Prof Anita van der Merwe, who is the chairperson of the Health Research Ethics Committee 2 at Stellenbosch University. She will be co-presenting with Professor Len Hansen, who is the chairperson of the Social, Behavioral and Education Research Ethics Committee. And they will start off our session with a presentation on the benchmarks of ethical human research from a health and social science perspective. And after their presentation, we have Dr. Debbie Marais. She is the manager of the Undergraduate Research Office at the Faculty of Medicine and Health Sciences and the coordinator of the Undergraduate Research Ethics Committee, which is a subcommittee of the Health Research Ethics Committee. And Dr. Blanche Pretorius, who is the head of the Health Research Ethics Office. So they will share information to you about the respective research ethics committees and processes at the Faculty of Medicine and Health Sciences. And finally, you have me, Ms. Clarissa Robertson. I'm the coordinator for the Social, Behavioral and Education Research Ethics Committee, and I'll give you a bit more information on what the REC SBE's processes entails. So we will allow time at the end for questions and discussions after all the speakers have presented. So we ask that you please note your questions in the chat if you would like us to discuss that at the end. So with that said, again, just a reminder to deactivate your camera and mute your mics during the session for minimal disruption. I will then hand over to Professor Anita van der Merwe and Prof Len Hansen to start their sessions. Thank you.
Thank you so much, Clarissa, and hi to everybody. It's a beautiful day, and we had a bit of rain, so that's good weather to talk about research ethics. You will see in the background of the first slide the famous Tuskegee study where African males were actually supposed to be treated for syphilis, but they were not, and they did not know. So unfortunately, health and medical research has really had quite a bare and sad history in terms of health research. And I think that prompted over time the importance of having proper communication and oversight in terms of health research ethics. Now, I just want to say firstly that what we consider most important in health research ethics would be participant protection in the first place, and then secondly, scientific integrity. Now, at the back, you will see the Nuremberg trial, and some people called it the doctor's trials because of the atrocious experiments that took place at that time, and for which people had to be seen and being told, this is not on, and of course heavy penalties were provided. But it also was the beginning of something beautiful, which is the Nuremberg Code. And if you read the Nuremberg Code, it's really the basis of everything and how we think about research ethics, especially within medical and healthcare research. Now, I'm not talking in detail about history, but I just thought this one example for me was always very informative. And that was the Havasupai trial in the Grand Canyons in the USA. And this community, very small community, is very difficult to get there. It's very, secluded. But they had, academics and people visiting them over time. So there was a time when an anthropologist visited them, and they talked to her about the huge issues around diabetes within their community. And then they thought in terms of discussions with the academics whether that maybe a genetic study on diabetes would be meaningful to help identify key factors. But unfortunately, the geneticists then continued because there wasn't really much on genetics and diabetes, and she then continued with some other stuff. stuff on schizophrenia, migration, inbreeding, and so forth. And it just then happened that a student presented a research study related to these blood samples in a public forum at the university. And in the audience was a member of this, who's a student, but a member of this community. And she knew about this, and she said, but this is not what we signed up for. And from there, a huge settlement process started happening with the specific university. Of course, the research scientist said she had broad consent. When that was reflected on, that was not true. And eventually, the university had to pay the community something like $700,000. They had to support scholarships. They had to help to obtain federal funding for a health clinic. So in the end, it cost the university about 1.7 million, this specific health research ethic issue. But for me, the sad moment was when I looked at a video where the members of this community came to the university and to the little place, the huge freezer where these blood samples were stored, and how they did a community recognition of the blood of those people. So what I'm trying to say, money is one thing, but what it does to the participants, if we do not manage our healthcare ethics meaningfully, is really very sad. So for us, we would say that ethical considerations seem to be always a section in a protocol, and that's it. Unfortunately, it's not. It's really from the conception of the protocol up to the eventual closure and publications, ethical considerations come through. It's a golden thread through everything we do. At the back, again, is a sad example of thalidomide, which was a over-the-counter drug that people could use for nausea, especially during pregnancy, and you can see the effect, children born without arms, for example. Now, what do we use as our guidelines? We basically have three things. The one which we really use a lot is a very landmark publication by Emmanuel et al., and that is what I will use as basis for my discussion. We also have the Department of Health guidelines and the Health Research Ethics Committee SOPs, which, and all of this stuff is available online if you ever venture into health research ethics or wish to just check something. Now, these are the 8 benchmarks that Emmanuel put forth. And although they kind of look as if they form a certain order, one can maybe deduce that, but also it's a very much to and fro process. Many of these happen within different stages of the research project. So let's look at the first one, which is community participation. Any research within health and medical, you have to do with the communities. And the preference is to actually prior engagement, to engage with the participants before, to hear what is their views, what is their understanding, how will they relate to consent, and so forth, what are the structures within the community. Now, of course, this is very difficult sometimes for researchers. It was especially difficult in the time of COVID. To do this, but it is, in our view, a very critical part of good health research. Secondly, sorry, the second benchmark is social value. Now, we all have a section in protocols, you know, what is the importance of the study and the significance and so forth. And that is so important, but we have to think what is essentially part of that, and that is that we do not expose any of our human participants to inconvenience, risk, or harm without any real benefit to the society. So the risk-benefit ratio comes in in my opinion, really in every study we look at any decision we make. It's always the participants' interest that's so interesting. Now, the third one is scientific validity or rigor. Now, I have to say, honestly, this is a very contentious benchmark for some of our researchers. In general, researchers don't like us to reflect on the methodology, the intricacies of the research design. But it is one of our benchmarks, and it is because we know that if it's badly designed, we waste resources, but most importantly, we expose our participants to inconvenience and risks, and our conclusions will be useless. So for us, that is very important. Now, there's a lot of discussion around quality research. The GIGO, for example, say, if you put garbage in, you get garbage out. So if it's poor methodology, whatever you find will really not be worth anything. Unfortunately, what also sometimes happens, because of the allure and the status of research sometimes, that it is garbage in and then it's believed at the end. It is seen as truth by the community of researchers or the communities we serve. And this, for me, underlines the importance of carefully reflecting on the value of research. The fourth benchmark that was promulgated is a very critical one as well, the fair selection of participants. Research ethicists feel very strong about justice or fairness and then treating everybody equally. And any research review will carefully look at that in terms of whether it's okay. So firstly, of course, which we all know, is that it must be in line with the research aim. So it must be, the selection must be inclusive and not discriminate in any way to anybody. We often, like sometimes people ask us, why do you want the informed consent form in all the languages? Because if you don't, then a person that, for example, is Xhosa or English African depending, they need to be able to reflect on the informed consent in their own language. So it is in all the details of the project. We also look at the participants in terms, will they be eligible and will there be any harm? And if there is, will the harm really be minimized as much as possible? Within medical research, often if you look at clinical trials, when you try out a new drug, there's always the uncertainties of what would be the side effects and so forth, even though it's been thoroughly tested on animals and in the laboratory. So all precautions to protect the participants needs to be on board. The vulnerability of the participants, we think specifically about research using children, women, I believe, just as important as, and so there are many people with mental health discomfort and so forth. The researcher needs to justify the inclusion of especially vulnerable participants, especially those who are not able to make an informed decision themselves. And what would be the safeguards to protect participants being selected? The third aspect of participant selection is that we distribute benefits and burdens fairly and equitably. So if there's any potential of benefit, it must be either direct or indirect, and it must be to all the participants who participate. And so that we fairly distribute whatever benefit there is. And exclusion of any participant without a sound justification. We, for example, sometimes see that a researcher says, I only want to use this population or that population, and there's not a clear understanding and explanation of why that choice was made and is so important. The fifth one, that's a kind of in the middle of the eight for me, is the favorable risk-benefit ratio, which I mentioned in the beginning, that it really goes through all we do and everywhere we think about a health research project. Researchers in our context are often very good to look at the clinical realities of a research project or intervention, but there's not always consideration for the psychological, the socio-psychological, the socio-economical realities linked to research that they do. And it is true that whatever you do has an effect on any of your modalities. So research ethics committees sometimes have to bring the researchers in terms of really looking carefully at all the possible risks and benefits related to the whole of the human being or the group that we are studying. And this is especially important when we think about the vulnerable groups, as I mentioned earlier, and also how the individual relates to the community. Is it an individual benefit, or is the benefit larger than the individual and relates to the community? And then, of course, if we think about, is there any compensation for a participant who may take a risk in some way to participate in the study? And I will talk a little bit later again about time. And we often talk, for example, in clinical trials about post-trial access. It's all fine if researchers wish to do or see if a new product works, but that product, if it works and everything works out well, it must be accessible to the community. So we expect researchers to, from the beginning, reflect on access to such a product. Now, within this risk-benefit context, there's these two things that we talk a lot about, and you probably have heard about them: anonymization versus de-identification. I'm just very briefly summarizing it. We know that if data is absolutely anonymized, it cannot be associated with any individual in any manner. Thank you. The data is stripped of all personal identifying elements, and it can never be reassociated with that the individual from where the data comes from. And of course, that is the ideal, and that is what we prefer, of course, always. But there are, however, times when the clinicians may need to actually do clinical follow-up or follow progress over time. And they may then request or put forth de-identification. So the patients are protected in terms of the important indicators such as name, patient number, ID, and so forth, but it's very controlled, and it's only by, for example, a specific person that will have access to it. It is, and whenever the data is presented, it is also aggregated, so that there's no, so the protection of unintended disclosure. So we do within health and medical research at times have to carefully look at why the researcher wishes to continue with the de-identification of data. Now here we talk a little bit in the 6 benchmarks about independent review. And that came about even from the Nuremberg Code and later that it's so important that, because we've been through so much in terms of sadness, is that we need to have health research ethics as a distinct field of study and distinct measures to actually do have independent review. Now, this piece of humor I thought interesting, you know, how many medical professionals are needed to change a light bulb. And then the answer is you need the light bulb's consent first. So HREC members, and you will see them on the right-hand side, they are really involved with and related to all of the people in this little humoristic drawing. So ethics committees, it's not an easy job. It's all of us within the university that are members of these communities and are really dedicated and passionate about ethics. So we really see a lot of, every study is actually important, and it's sometimes very impressive documents, the protocols, the CVs, they're complex, they're not easy to work with. We work with prominent researchers, sometimes people with quite a presence and a persona, with teams within and amongst and across the world. So it is a very interesting exposure for health research ethics committees, but at times it's quite taxing. We also now more and more work with mutual recognition across health research ethics committees. In the time of COVID, we realized, because with the clinical trials for vaccines, for example, that we work with other committees in the country. We actually have a group that now is in regular email contact and discuss matters. And we looked at reciprocal review, where we look at ways to accept the reviews of other HRECs when we have the same study at another site. The importance of legal scrutiny. Although ethics is not legal, it transcends legal matters, but it is important to always be in line with what is stated within the different laws and regulations. So, for example, in my committee, there is a lawyer that is part of the committee. And then we also we have an interesting relationship. We actually report to the National Health Research Ethics Council. We don't report per se to the university as an entity. There's a different lane that we follow, and that's actually also to support the objectivity, if there is something like that. Then I just said about the messiness of ethical dilemma. It's really, nothing is very clear, nothing is pure. There's always different ways to see a matter, and that's why the discussions within the ethical committees are so important, is that we really have a discourse and come into a consensus on the way forward. The seventh benchmark, which is the second last one, is the critical one of informed consent, which means no study, all studies must consider all 8 benchmarks, and of course informed consent is one of the realities and documents related to informed consent that we carefully scrutinize as health research ethics reviewer. We have also a specific template online that we prefer researchers use to make sure that all the elements of informed consent is included. What do we look at? That it respects the participants' autonomy, that it is clear in simple language that the participant can understand, that the participant can then make a choice based on what they understood, and if necessary, that there will be support for the participant to understand. Thirdly, that the informed consent says very clearly it's voluntary. You may participate if you wish to. It's a free choice, and you make that in line with your own interest, values, and preferences. So there may be no undue influences. Okay, if you participate in that, you will have a free meal at so-and-so, or there's a huge voucher of this that you will get. All of these things we've seen, and they are not at all permissible. They only allow for time, inconvenience, and expenses, which is time. The last benchmark is the ongoing respect, which in a way talks about, as we go through the study, in all its different studies, from the contemplation, the design, when we do it, when we monitor, and when we disseminate. is that the respect of the dignity of the participant must be visible and clear all the time. Confidentiality, right to withdraw, the welfare and support. And welfare and support is about, for example, if the participant is uncomfortable with a certain intervention or with a certain, so for example, it is within mental health or psychiatry, and the participant is really struggling with what he's sharing, then there should be clear support for that participant, and that will be stated within the initial document that is submitted to HREC. And then, of course, the whole matter of dissemination of research, and especially to the participants as well, and then the community of researchers. So you see this huge Biomedical Research Institute. This was just the architectural drawing. So you will see that within the Faculty of Medicine and Health, there's a lot of things happening. And this institute is a research institute. So it will, and it's already creating additional important research. Now, of course, my question would be to the powers that be, have we also reflected on the influence of such a huge institute on the capacity and abilities of health research ethics committees? Because it will have, so any enlargement, new facilities of a university has an influence, especially if universities like ours say that our huge thing is quality research. That is where we put a lot of effort in. So in summary, the huge thing for us is the minimal risk to participants, if any, which relates to ethical integrity and scientific integrity. The risk benefit is a key matter, and then the 4 matters related that I have discussed with you. So this, if you're interested in the slides, we'll give you a kind of a summary of the H benchmark. So thank you very much for this opportunity. Thanks, and I hand back.
Thank you very much, Anita. Should I just go on from here, Clarissa?
Yes, please, Professor.
Good afternoon, colleagues. I am Len Hansen. As you heard, I am the chair of the SBE REC. I will share my slides with you, but I will switch off my camera this side. I think if you have to look at my face for half an hour, that would already constitute what we call in ethics circles an adverse event. So I'm just going to switch over to my slides. Right. So today you are treated to, or subjected to, whatever way it pans out, to the views on research on human participants from 2 perspectives: that of the humanities, of the social science REC, and from the health research REC. We do the same job and we apply the same ethical principles, but in very different environments, and we do very different research, and sometimes we are also subject to different statutory rules and regulations. In general, social science, however, when compared to health sciences, is often considered to pose mostly low risk to its subjects, and therefore it needs less stringent review from ethical review committees. It is, of course, true that health sciences often work with bodies, with the physical lives of participants, but I hope to show that research ethics also concerns more than the potential loss of life or limb. And indeed to show, as Anita also did, how we think at the research committee, and also to help you understand that we are not just trying to complicate research. All right, since we are in the humanities, I think a historical overview of why and how we came to this point where we have research review, ethics reviews and ethics committees, why we have discipline or occupation specific or institutionalized, even sometimes globally accepted rules of ethical research. Because as someone said, research methods are neutral, but individuals applying them rarely are. And this is true both in the health and the social sciences. And our biggest lessons on how to conduct ethical research we have learned from both, particularly where research went ethically horribly wrong. Right? So if ethics deals with values relating to human conduct with respect of rightness and wrongness of certain actions and to the goodness and badness of motives and ends of such actions, it is as old as human civilization itself. Medical or then research ethics, not so much. Although the ethical quandary was already clear in the first century physician Celsus' comment that it's not cruel to inflict on a few criminals sufferings which may benefit multitudes of innocent people through all centuries. But fortunately, ethics regarding research on human subjects also changed considerably since Celsus' time, but it was a long and arduous journey. Closer to our own age, the first human subject research experiments were documented in vaccination trials in the 1700s. In the early trials, physicians used themselves or their family members as test subjects. In England, Edward Jenner first tested smallpox vaccines on his son and on neighborhood children. And the German gynecologist, obstetrician, and pediatrician John York apparently swallowed 17 drugs in various doses to record their properties. Now, I'm not a physician, but I don't know, if his fields were gynecology and pediatrics, whether any of this would have been of any use. But anyway, we also all know about Louis Pasteur, the father of bacteriology, who apparently agonized over treating humans, even though he was confident of the results obtained through human trials. Now, the modern era of science started in the 1900s, and the progress of medicine began to accelerate. An early example of research with human subjects was Walter Reed's, he was an army physician in the United States, experiments in 1901 that led to the development of an inoculation for yellow fever. His research showed that yellow fever was spread by a virus carried by mosquitoes rather than by direct contact with infected persons or via contaminated water. But Reed did use human volunteers, including soldiers. And some of the medical personnel who followed, were part of these, the participants, and they allowed themselves to be bitten by mosquitoes infected with yellow fever. Right. So during World War II, and Anita also referred to that, Nazi doctors conducted as many as 30 different types of experiments on concentration camp inmates without the consent of the victims. And they suffered indescribable pain, mutilation, permanent disability, or in many cases also death. And then after the war, at the so-called Nazi doctors' trial, as part of the Nuremberg military trials of 1946, 23 physicians were charged with conducting inhuman experiments on both German civilians and nationals of other countries. And then of the 23 defendants, 16 were convicted and 7 were sentenced to death. But this led to a very important milestone in research ethics. When the Nuremberg Code was formulated in 1947 by the International Military Tribunal. And it set new standards and an ethical yardstick for research on human subjects. It was also the first internationally recognized code of research ethics, and the principles of the code include things that are now obvious to us, such as voluntary consent, benefits outweighing risks, and the ability of the subject to terminate participation. Now, some other interesting developments was in the post-war times was, for instance, the Willowbrook hepatitis study, where in 1956 an institution for mentally retarded children in Staten Island, New York, a study was initiated to determine the natural history of viral hepatitis and to test the effectiveness of an agent for inoculating against hepatitis. So children were deliberately infected with a mild form of hepatitis, and although permission to use the children, in a manner of speaking, for the study was obtained from the parents were not fully informed of the possible hazards involved in the study. And there was also evidence that parents were led to believe that the child would not be enrolled at the school unless the parents signed the consent form. So here clearly ethical problems such as the exploitation of vulnerable subjects or withholding information about risks and coercion or undue pressure on the parents to volunteer their children came into play. In the study that Anita also referred to, the thalidomide study of 1961, medication was approved as a sedative apparently initially in Europe in the late 1950s. It was never approved, the drug was never approved by the FDA, but then samples were sent to US doctors. And by 1961, it was shown to be very harmful to a fetus, interfering with the normal development of arms and legs. And this then led to the passage of the Drug Amendments Act of 1962, to the Food, Drug and Cosmetic Act as well. And this was the first of the US statutes that required subjects to be informed of drugs a drug's experimental nature. So the ethical problem here was full disclosure. Sorry, let me just bring those back. Right. Clarissa, can you see them?
Yes, I can see it, Len. I think you should be on slide 7 now.
Yes, let me just get there. All right. So then there was also in 1963 the Jewish Chronic Disease Hospital study, where a hospital in Brooklyn in New York, live liver cancer cells were injected into senile patients without their knowledge as part of a study of immunity to cancer. Since the investigators believed that the cells would be rejected, the researchers did not inform the patients to seek consent because they did not want to frighten them. And the ethical problems here, obviously, would be a lack of informed consent, again, the use of a vulnerable group of subjects, and power relations, unequal power relations between the researchers and the patients. Then in 1968, we find the Tea Room Trade Study, which was a study on homosexual practices in public restrooms and on the men who took part in these acts. The researcher went undercover and gained the confidence of the men by acting as a lookout. The researcher then identified 100 active subjects by tracing their car license numbers. And a year after he completed the initial study of direct observation of homosexual acts, the researcher distributed a social health survey through the communities where he knew the subjects lived. And of course, again, a vulnerable population. Deception came into play, confidentiality and anonymity, and a lack of informed consent. Then in 1971, we find the San Antonio contraception study, where in San Antonio in Texas, a number of Mexican-American women participated in a study to determine the side effects of oral contraceptives that they received via a free clinic. But unbeknownst to them, the study was designed so that half of the women would receive oral contraceptives for the first half of the study and then switch to placebo. And the women initially receiving placebo were then placed on oral contraceptives for the second half of the study. And 10 of the 76 subjects became pregnant while using placebo. The ethical problems, again, was a lack of informed consent, the use of a vulnerable group, the Mexican-American women here, and power relationships, and also the risks outweighing the benefits of the study. Then the tea room example, as well as the obedience to authority study of the Milgram study, were two studies that were not health related. Those were in the humanities. But the famous obedience to authority study was a study to determine the response to authority in normal humans, where researchers told recruited volunteers that the purpose of their study was to study learning and memory. And then each subject was told to teach a student, in quotation marks, to punish the student's errors by administering increasing levels of electric shocks. The so-called student was a co-researcher who pretended to be a poor learner and mimicked pain and even unconsciousness as the subject increases the levels of electric shock. Amazingly, 63% of the subjects administered lethal shocks, some even after the student claimed, the so-called student claimed to have a heart disease. Some of the subjects, even after being debriefed, experienced serious psychological trauma. Now, the ethical problems here, again, deception and unanticipated psychological harms. The final study that I want to refer to is one that Anita also referred to, and that is the Tuskegee syphilis study. So where the natural history of syphilis was investigated in African American men. There was no treatment for this condition at the time. The men were recruited without truly being informed. They were deliberately misinformed about the need for some of the procedures. For example, spinal taps were described as necessary and as a special free treatment. And even after penicillin was found to be safe and effective treatment for syphilis in the 1940s, the men were denied these antibiotics. The study continued to track these men until 1972, when the first public accounts reached the press. The study resulted in 28 deaths, 100 cases of disability, and 19 cases of congenital syphilis. So ethical problems, lack of informed consent, again, deception, again, withholding information, withholding available treatment, putting men and their families at risk, and exploiting a vulnerable group of subjects who would not benefit from participation. So with all of this happening, how did the international community and governments respond? So because despite of the Nuremberg Code, as was seen, the ethical transgressions continued, and the principles in the code of the Nuremberg Code were over time extended, redefined, and encoded in other globally accepted codes, statutes, and in different countries, or in occupational ethical codes. And the most important ones that I just quickly want to refer to, and the gist of these codes, would be the Declaration of Helsinki that in 1964 was accepted by the World Medical Association. It was widely regarded as the cornerstone of human research ethics, and it was to a high extent a reinterpretation of the Nuremberg Code with an eye to medical research with therapeutic intent. Subsequently, also, journal editors required that research be performed in accordance to the Helsinki Declaration. And it has already undergone 7 revisions and 2 clarifications, growing from 11 paragraphs in 1964 to 37 in 2013, as medical science and society and political systems and legal systems also developed. Then the Belmont report is a direct result of the Tuskegee syphilis study that we referred to just now. That study led to the so-called National Research Act in the US, and a National Commission for the Protection of Human Subjects was also established, and it compiled the so-called Belmont report in 1979 that required the following 3 principles for ethical research: respect for persons or autonomy, beneficence, and justice. So with regards to the respect for persons, individual mental capacity and voluntariness were emphasized. And these had then implications for informed consent, for privacy, and the provision for discontinuation of a study, also by the participant. Then beneficence emphasized the risk-benefit ratio with implications for minimizing risk as far as possible, and the requirement that research personnel be qualified to do the research that they undertake. And then finally, justice is emphasized the requirement to treat people fairly, and this then had, as Anita also referred to, implications for participant selection and for the benefits arising from participation. Then interestingly enough, a very influential, two very influential codes that were accepted. The first one, the American Psychological Association Ethical Principles in 1953, and the American Sociological Association Code of Conduct in 1970, are both quite influential in the world, and it's also quite comprehensive. For instance, the APA code give 5 general principles and 10 ethical standards that are much that are to a large degree in line with what has already been said regarding the requirements for ethical research. Now, the REC SBE functions within the framework of all relevant promulgated acts of Parliament and international treaties and conventions where South Africa is a signatory of, interpreted in a manner appropriate to research in the humanities. So that is that also. Oops, what am I doing now? Sorry, let me just get my place again. All right. So there are quite a lot of regulations and policies that the REC has to follow. You will find a whole list of that in the REC SBE SOP. But this includes acts such as the Constitution of South Africa, the National Health Act, the Children's Act. Very important nowadays, the POPI Act and the PAIA Act. On protection of personal information. Also, United Nations Conventions on the Right of Persons with Disabilities and optional protocols. Also, the Stellenbosch University Policy on Responsible Research Conduct, so that we have our own policy as well, not only all these international or national ones, but also our own research policy that we have to abide to and that we have to apply in our reviews. But then there are also certain ethical principles that the research ethics committees subscribe to. Those that are contained in the Belmont Report, in the Declaration of Helsinki. Then the more recent ethics in health research principles and process and structures of the Department of Health that Anita referred to. Also the Global Conduct for Research in Resource Poor Settings, that one is quite recent in 2019, and the Singapore Statement on Research Integrity. But then there's also policy and guidelines. Policies and guidelines that we refer to with the responsible research conduct at Stellenbosch University, that's one. The university's procedure for the investigation of allegations of breach of research norms and standards. Whenever that happens, we need to follow the process as explained in that policy. And the Universal Declaration of Human Rights. Again, there a much broader guidelines in that one. And then we also look at guidelines of professional bodies. We look at the ASA, we look at the American Sociological, the ASA and the APA codes of conduct, but also for social workers, for instance. And we also apply those. And sometimes when you review something and we have reviewers from that environment, they would look specifically for things that are applicable to psychological or sociological or whatever kind of research that they specialized in. Right, so now we understand more or less where we kind of burnt our fingers as to how we came to the point where we are today. Now, all research that involves human beings carries some risks for the participants, all right, including that research that's conducted in the social sciences. Social science research is highly dependent on interviews with cooperating subjects. It records records the experiences of people. It also engage in records of people that are living or recently passed away. Sometimes unobtrusive observation is used, or participant studies with interacting groups. And many of these research projects also concern very sensitive subjects. Now, examples of such sensitive subjects that one finds in social research is for instance, information related to sexual attitudes, preferences, and practices. That's immediately a red light that goes on for any reviewer. Information related to the use of alcohol, drugs, or addictive substances. Information related to illegal behavior. What are you to do if one of your participants admits to having perpetrated some crime? Information that, if revealed, could damage people in terms of their financial status, their capacity to pursue employment, or their reputation in the community. Remember the study on the tea room study? That would be an example of this, for instance, which was, as I said, also conducted within the social sciences. And then information that normally would be registered in medical records and whose revelation could lead to stigmatization or discrimination. We've had, with the onset of HIV and AIDS, we have had many of these kinds of studies that needed access to people's medical records that showed that revealed their HIV status, and that caused a lot of problems. Anita will also tell you that, especially this is also a very, very important principle specifically in health sciences, because they work on a daily basis with people's medical records. And then information related to the psychological well-being or mental health of individuals. Then another thing that also I think distinguishes somewhat social research, social science research, and health research is also the risks involved. The risks, as I said, not often are people in life-threatening situations, or where there's very real physical risk. It does not mean that it does not happen. For instance, when you do studies, we've had studies where people worked among sex workers that had pimps, and that if they would participate in the research, that might cause them to be the targets of the aggression or the anger of the pimp, for instance, or when you do research among gang members. You know, the information that is shared there might put the gang member in, or the former gang member then in a very bad position should it come out, or say in prisons, especially gangs in prisons, when members divulge information there that might put them at risk of their lives. But otherwise, the classic examples of risk in social investigations are studies of maltreatment, which imply putting persons that give a testimony in a situation that makes them to revive traumatic moments of their lives. And for this reason, the REC SBE applications emphasizes mitigating steps to either prevent this or to address this should it happen. Another important issue is that of privacy, anonymity, and confidentiality of information. In this day and age, where information on people are only the press of a button away via the internet, for instance. So especially, you know, when it's also related to stigmatized behaviors such as delinquency. Or homosexuality in some context, drug use, or mental illness. And this also poses a risk not only for the participant, but it actually poses a risk also for the whole field of study. Because as I quote here, the former Washington Post columnist Nicholas von Hoffman, who said that we are so preoccupied with defending our privacy against insurance investigators, dope sleuths, counter-espionage men, divorce detectives, and credit checkers that we overlook the social scientists behind the hunting blinds who are also peeping into what we thought were our most private and secret lives. So much of what the REC does is to look at the assurances given by researchers that the privacy and anonymity and the confidentiality of shared information are protected. And part of this is also whether all information is actually required, whether to make this a successful study, you need this information. And this is why applying for ethical clearance expressly asks researchers to respond to questions such as their compliance with the POPI Act, gatekeeper permission to access and recruit participants, the inclusion of personal identifiers, and demographic information of participants. In South Africa, the issue whether racial categories or how to use racial categories within research is a very, very sensitive subject, as we all know. And then finally, also on how data will be stored. And constantly, this also develops as we all know that data, even the proverbial cloud in the sky, is not always as safe as we would like to be. Then the revelation of shared information can put the subject at risk of criminal or civil liability. We already talked about that, but also can damage the economic position, employment, or reputation. The validation of inappropriate or undesirable behaviors. It might be that somebody is participates in a study on an undesirable behavior, but misunderstands the study and think that this is actually something good because it's being investigated. So there's a misunderstanding of the intention of the investigator. And then possible damage to individuals that do not participate directly in an investigation, but because they belong to a class or group from which subjects are selected. And I have to tell none of you, I'm sure, about the so-called colored women study at Stellenbosch University, where exactly this had happened. It had a very traumatic form part of that group. And then it can also cause damage to the dignity, the image of innocence or innocence of a subject as a result of indiscreet or inappropriate questions for the age in interviews or questionnaires. And that's why we also always look very intensely at the questionnaires, at the tools, the data collection tools, and ask whether this is appropriate, whether the register is one that will be understood by a specific age group or section of society. Then, in all of this, as you now surely saw, the Research Ethics Committees, not only SPE, but also the health sciences, play an important role. And James Sieber, in Planning Ethical Responsible Research, wrote that the role of the Institutional Review Board is to determine whether the rights and welfare of the subjects, and I added here natural as well as legal persons. We're looking at study of human participants in this session, but also remember that RECs also have a duty to look at the possible risks for legal persons, for institutions, for the university, of what the implications of unethical research will be for companies or for universities or whomever, for those institutions with whom the researchers are affiliated with. But also we have a responsibility to look after look at the risks that the researchers impose on themselves. So in those cases, for instance, if you work in a situation such as with gang members, it is also the duty of the REC to look at how the researcher protects him or herself in the process. The role then of the Institutional Review Board is to determine whether the rights and welfare of the subjects are adequately protected and whether the study adheres to sound ethical and scientific principles. And with that, I've come to the end of my presentation, but I underline the scientific principles here because I totally share Anita's comments and feelings around this, because this has always been an issue at REC on ethic reviews committees, whether a REC can also comment on the scientific principles. Anita gave very good reasons why that is necessary. We often accused of mission creep and that we're overstepping our lines, but this is in fact, and then we always have to remind people that this is actually expected from us, not only on grounds of good ethical research practice, but also by law. And with that, Clarissa, thank you very much. That is then the end of my part on research ethics in the humanities.
Thank you, Len. Next, colleagues, will have Dr. Debbie Marais and Dr. Blanche Pretorius presenting on the Undergraduate and the Health Research Ethics Committee procedures. Colleagues, Debbie, please go ahead.
Thanks, Clarissa. Let me just try and coordinate sharing my slides. Okay, I'm hoping that you can all see that. I'm not able to keep an eye on the chat, so Clarissa or anyone, please shout at me if there are questions or anything that's going wrong that I need to attend to. The reason we sort of decided to start with UREC, which is a subcommittee of HREC, is because a lot of the UREC essentially follows the same administrative processes and procedures as HREC. It applies the same guidelines, but it's kind of like the sort of baseline because we review student research. And so we're starting with that, much of which will also apply to anyone applying to HREC for approval, but then Blanche Pretorius will add on to this from HREC's perspective. So just to give you the context, you're hearing a lot of people speaking today, and all of the committees that are talking to you today. Is that someone telling me something's wrong? No. Okay. Are registered with the National Health Research Ethics Council, and then we also report to the Stellenbosch University Senate Research Ethics Council. And that's important to know because the HRECs, although they are located within the Faculty of Medicine and Health Sciences, and UREC is a subcommittee of those committees, also located in the Faculty of Medicine and Health Sciences, we serve the whole community, the whole university community. So anyone who does that kind of research would submit to us. I'm sure that Clarissa will refer to this, so I'm just quickly sharing it on screen, but it's a good resource on the DRD website with, if you're unsure about where you're supposed to go first or who you're supposed to apply to, we put together this infographic to try and help you to make that decision. So I'm speaking specifically to the UREC side of things. I am the coordinator of the UREC committee, and I am going to be pretty much doing a very quick run through of all of the resources that are available to you. So I'm not going to go into detail on any of it, but hopefully I'm just going to be able to point you to the things that might be needed by you if and when you're applying to these committees. So this is our website. It's a go-to in terms of information and guidelines. I'm pointing out specifically there are submission deadlines and also what I refer students to always, which is our frequently asked questions page. So if you're unsure, I always say this is a good place to start. You'll see that in general we try to address the kind of many common questions that come through, and you'll also find that there are lots of videos. So if you click on any of these, some of them will take you to videos that address some of these issues depending on the type of study you're doing, or guidance documents that should hopefully give you some clear guidance on these issues. We've also got at the bottom of that page videos on how to actually navigate the online ethics application system. So if you don't know already, it is an online process. And as you can see, there is also video guidance on how to actually take it step by step and get through that application and what you need for it. So that's important to sort of perhaps watch up front. Just to also reference a couple of things that I think also Len pointed out specifically, that it's not just about the ethics guidelines. There are all sorts of research-related policies that do come into play when you're applying for ethics approval. And I have just included screenshots here of some of the really important ones. Again, it might depend on the kind of study you're doing, but in general, this is a good go-to if you are wanting to make sure you're abiding by Stellenbosch University's responsible research conduct policies and regulations. And then Len also mentioned the Protection of Personal Information Act, which is of course relevant now for any of us who are processing any kind of personal information. Research information is part of that. And if you're not already aware, we've got a Division for Information Governance that does help with that. They've got a page that offers some guidance on how to navigate POPI, and they've got a self-assessment tool, which I'm pointing out here for you to do, just to do a sort of privacy assessment to see what level of risk your information that you're collecting would fall at. Some important links: the applyethics.sun.ac.za site is the one that you go to start completing your ethics application. And then I've also included the links to the Health Research Ethics Office, which kind of provides the home for the two HRECs, Health Research Ethics Committees, and then the link to the Undergraduate Research Ethics Committees pages. So to give you a quick background on what you need to do, you need to leave enough time to do an ethics application. Don't think that you will get it done in a day or two just before the deadline. So start anticipating what you need up front quite a lot ahead of the time. Check the submission deadlines to see when you need to, or planning ahead when you want to be submitting by. And make sure, I think I saw many of the participants here already do have Sun email addresses, so you'll have a Sun ID and password, but it's really important for you to check perhaps also really early on that you can actually log in using that. You should be able to, there shouldn't be any problems, but if you can't, then you want to get that sorted out before, midnight of the deadline. Ensure that you have all the information. There's a lot more information than I think people anticipate that's going to be required when you apply for ethics, and also all the documents that are going to be required. It's not just one thing, it's lots of them. So I'm giving you a snapshot here of our deadlines, UREC's deadlines for 2022. If any of you have already perused the HREC website, you'll see that our deadlines are the same as the HREC deadlines. The double 6th of July is not as a mistake. It's because HREC 1 and HREC 2 share a deadline on the 6th of July, but this pertains to those two committees. So you can see roughly that there's about 2 a month, every 2 weeks. I'm not going to go into a lot of detail about this sort of Sun ID stuff because I'm assuming you all have it, but it's really, as I said, important that you ensure that you have one, and that's not an ethics office process. So if you don't and you need to apply for one, that's your department or division's responsibility to help you with that. It's not an ethics office thing that we can help you with. However, we do have a lot of guidance available on the ethics sites to sort of direct you to where you need to go if you are struggling with getting a Sun ID. And the reason that that's really important when you apply for ethics is because it automatically pulls in your contact details and populates some of the form from the HR or student admin systems, and you won't be able to change that. So it will also use your email address that it pulls in to communicate from the ethics office all of the feedback letters that you're going to maybe receive on your ethics application. Okay, so I just wanted to emphasize, we've spoken a lot about the sort of violations that have happened, and I think some people perhaps kind of think, and I obviously deal with students quite a lot, that ethics is just a section you add on at the end of something and that's that. So I just wanted to emphasize that it should feature in your research protocol or proposal pretty much in every section, and that's where we're looking for ethics stuff. We're not just going to the end of the protocol where it says ethical considerations. So this is just to give you an idea, the minimum set of documents that most health research ethics applications are going to need. Probably depending on the kind of study, you may need more than this. So there's a research protocol, that's the biggest, most important document, also called a research proposal. Then a protocol synopsis, which is a summary of that. You need to submit CVs for whoever is working on the study. Investigators' declaration forms, which you can download from the website. There's an actual form that you will need to complete, and you need to submit a budget for your research. You also need to submit what we call the HREC payment instruction form, also can be found on the HREC forms and instructions page. And even for student projects that are exempt from paying the fees, you still have to fill in that form and put the 0. Then if you are collecting data from human participants, you have to do the informed consent and assent forms that you've adapted for your study, or if you are asking for a waiver of that consent, you need to formally submit that letter with your application. And then any data collection materials that you might be having depending on your study, your questionnaire, interviews, and so on. An assigned signature page by the HOD of your department or division. So you can see why it's important to plan ahead and to plan for all these things, because you can't expect them to be signing something the night before when you're trying to submit for ethics. So just quickly on UREC, we review all sort of student, and that's both undergraduate and honours level student research, so that's important for you to know as well. And any minimal risk research comes to us at UREC of undergraduate and honours students. This is the definition of minimal risk, so it doesn't mean no risk, but it is minimally invasive kind of research where the probability of harm or discomfort is less than that would be, or no more than that, than would be experienced in daily life or during routine examinations or procedures. Once you've submitted, you've gone through all of that and submitted, what happens, it gets routed to your supervisor if you're a student, and that will be the case for UREC, to sign off first on the online system. So check that they've got that and that they've seen it and they're going to sign off before the deadline. You should get an email notification once you've submitted and your supervisor signed off. And then there's an admin check. So Lauren Hendricks is our administrator at UREC. She does a check to see all the right stuff is there. If not, she'll contact you and say changes are requested. And if everything's complete, then she forwards it to me as the UREC coordinator. And because it's minimal risk, then I can send it to one UREC reviewer who does the review. This is what you're looking at in terms of timing, generally, just to give you an idea. Usually within 2 days of submission, it's gone out for review, provided it was complete in the first place. And I give my reviewers on UREC, and it differs per committee. I give them 1 week. So usually you can get the feedback letter, the first feedback letter, between 1 to 2 weeks of the submission deadline. And you can expect that that feedback letter is going to ask you for modifications. That's what I tell everybody. So just expect that and plan for it. You can work on the modifications as quickly as you want. You don't have to wait for another deadline. Resubmit as soon as you've done them. It goes back to their original reviewer to check. And once they're happy, I also then have to give it to our chair to check and then have to sign off the approval. So I usually say leave at least 6 weeks before you want to start collecting your data, and plan to submit 6 weeks before that. And then finally, just the review decisions, what do they mean? So this is what you can expect to see on a feedback letter from the ethics committee. There is also a rejected option on the back end there. We haven't ever had that at UREC, which is why I haven't included it, but perhaps Blanche will speak to it. Approved is the one that you hopefully get, well, you will get at some point, hopefully, but it obviously means the study can go ahead and you can start data collection. Approved with stipulations means that you can start your study, but there are stipulations that still need to be done, small minor things that need to be done that the ethics committee is happy for you to do with your supervisor. They don't need to see it again. Modifications required is 98% of the feedback decision that we give at UREC, and it's usually because there are some issues the ethics committee wants you to address, often with consent form stuff, often with the scientific validity of things, and then you need to resubmit for us to review. You're not allowed to start your study until you've done that and until you've got the approval. And then deferral is also quite rare for UREC, although we do sometimes have it where there are quite substantial problems with the whole study and the protocol, and quite big changes are needed. Just to once more just refer you to our frequently asked questions page, and the reason I'm providing the whole snapshot here is you can see at the top there's a note about guidance on COVID, which we put together at the very start of the COVID lockdown when there was an embargo on face-to-face research. So you might want to just go and have a look at that so you can be sure that you are abiding by, doing research still during a pandemic. And then there's lots of resources around a quick guide to applying for ethics approval. There's a video on what HREC and therefore UREC reviewers are looking for in your application. So that's a good go-to. And then we have also included the review criteria guide that HREC and UREC reviewers use when they do a checklist and go through your applications. So if you want to double check yourself, that's a good place to go. And the first place to start really is to then go on to how do I submit a new online ethics application. And that's who we are. I'm the head of the undergraduate office and also the coordinator, and there's Lauren's face, so you can see who she is, and she's the UREC administrator. And that is it from me.
Thank you so much, Debbie. Dr. Blanche Pretorius, if you are available, then we can jump into your session immediately. There we go.
Thanks very much, Clarissa. I'm going to talk as I share because I'm very mindful of time and that we're not going to get much question and answer time in as such. Can I just go here? Are you seeing my screen, Clarissa?
Yes, yes, I am. You just need to maximize your
slide. Yeah.
There we go.
Do that. Oopsie, it's running away with me. Okay, so basically, if I can just start by saying that to actually cover too much of the processes in the interest of time. So I'm going to talk just briefly about who we are, a little bit of the structure of HREC, how we process our work and the operations, in other words, the back office, submitting an application, application categories, and a few other important issues. So on your left, you have the two health research ethics committees chaired by Dr. Marais and Prof Anita van der Merwe. And we, as an entity within the university, actually are accountable to the Senate Research Ethics Committee. Our office, called the Health Research Ethics Office, is the support arm of this particular endeavor. I'm not going to look at that slide, but just to again stress that research ethics committees in South Africa do a due review of scientific and ethics. So I think what I would like to actually just leave with colleagues and students is that I would really long for the day when we do not see ethics submission as an adversarial process, but rather one of sharing, peer review, and also just giving different perspectives. So do you see the old lady or do you see the young lady? My colleagues have spoken a lot about the ethical benchmarks, so I'm not going to go there. As I said earlier on, we have two health research ethics committees, namely HREC 1 and 2, and they both meet 10 times a year. So you have opportunities throughout the year to actually then submit. HREC 1 meets on the first Wednesday of the month from February to December. HREC 2 on the third Wednesday of the month from January to November. And please, what is important is that in July we go into recess, which allows us time to actually just consolidate, also look at any system enhancements that need to be made. So it's very, very important, as Debbie said, to plan ahead, ensure timely submission, and budget sufficient time to allow for review, responding to communication about outcomes, and also submitting responses. On your screen, you will see the submission and meeting dates for HREC 1 and 2. And like Debbie said, you have 2 opportunities in a month to actually submit. And contrary to urban legend in the system, HREC 1 is not any stricter than HREC 2. It actually doesn't matter which committee your submission goes to. There seems to be some urban legend that one defers studies or is much stricter than the other. As Debbie mentioned, it is an electronic application system, and this submission is then categorized based on study risk levels, and that is based on participant vulnerability or capacity. So you would either be in the expedited review part of the process, or your submission would go for full committee review. What I must just point out is that sometimes studies are actually labeled as expedited review, and then when the reviewers actually start to work with the particular protocol, for some reason or the other, it could be actually referred for full committee discussion. So on the landing page of the SU HREC, you will find that your first port of call is all the forms and instruction, and you will see that there is a section for new protocol applications. And it's as easy as just putting in SU HREC, and you will be taken straight to this landing page. Categories of submission are under health research projects. That includes also your student projects, clinical trials, case reports, the exemption category that we have, which is for studies which involve secondary data in the public domain, for instance, systematic reviews or scoping reviews, or where we are involved with some sort of meta-analysis. We also have a category for databases, registries, or biobanks, and then a list of ongoing submissions. So you might have had a health research project already approved, but you would like to amend it, either because your pilot project finds that you haven't accounted for something in the context in which you are researching, and you might then submit an amendment. We also need to just remind our applicants that every year you are expected to actually reapply, or at least to continue your ethics approval. So that is done by submitting your progress report at the end of the year, and your year is based on when your project was approved. So that is not a calendar year. If there are any protocol deviations, you would need to actually let the HREC know, as well as any adverse events. I'm not going to worry about this slide because Debbie has spoken to it. What is very important to just point out, in the section on new protocol applications, you will see that there are also suggested study methodology options. So please, if you are unsure about where your study design actually falls, the HREC has spent with some collaborators from the faculty an inordinate amount of time trying to streamline the process of the identification of study designs. So please do have a look at that. As Debbie said, once your submission has been received, it's gone through an admin check, it goes either to expedited review or to full committee review, you will get an outcome either of approved with stipulations, etc. The rejected category is one that we don't like to actually append to an outcome, for the simple reason that we know that it upsets the researchers as much as it upsets the reviewers as well. What that does mean is that we do not want you to then resubmit that particular study. And you will get the benefit of feedback so that when you are rethinking a study, then you know why it's been rejected as well. You can definitely budget about 4 to 6 weeks for a turnaround time on expedited reviews, about 4 weeks, and then committee reviews about 6. So just who will contact you is the HREC coordinator. For HREC 1, it would be Ms. Melody Shana, and for HREC 2, it would be Brightness Nxumalo. And then obviously the other place where you can check on the status of your submission is online. You will get some indication of where your particular submission is in the system. Please, we are people, and it's important that you do contact us for help. If you have any system-related issues, while you are busy doing the application or the review, Alvara and Ashleen are your go-to people. You can either contact them directly or via the ethics@sun email address. Also, the committee provides what we call a consult service, and basically what that is, if you are unsure about your particular protocol and whether it would be acceptable or not, or if you have particular questions around maybe the methodology and so on, it's important that you do ask for help rather upfront and not do a submission and then get comments that are perceived as negative. Thank you very much, colleagues. Dankie enkosi. And I look forward to any questions. Thanks, Clarissa.
Thank you, Blanche. So colleagues, we have about 3 minutes left, and I'm going to try my best to present the research ethics, the social behavioral component of the institution's approach. So if you would just allow me, I'm just going to try and share my slides with you. And I will share the slides after the session as well. But I think some of the key things that I just want to, in short, mention to you is, let me just get here, is when to apply, because we've now heard the perspective or the procedures for the Health Research Ethics Committee processes, which have been described in detail, and now when. And there's always this, and Blanche would be able to confirm this, that there's always a kind of a discussion around when do you apply to the Health Research Ethics Committee, and then when do you apply to the Social Sciences Research Ethics Committee. So I'm Clarissa Robertson. Sorry if I didn't introduce myself. I coordinate the Research Ethics Committee, Social and Behavioral Sciences. And when you need to apply to the Social Sciences, of course, if you are doing, and I'll put it very bluntly, or in obviously it doesn't justify everything, but in terms of non-medical research. So if you're doing research involving persons or groups, you need access to their personal information, and it is in a non-health context, then please reach out to me and I will be able to advise you accordingly. Our committee is also registered with the National Health Research Ethics Council, so naturally we also have to abide to their principles and rules. Then if you need information about how to apply to the committees, I think that Debbie and Blanche mentioned, we also have an online research ethics committee process or application process. So I would advise you to please visit our website, play around on the website, look at the dates for submission. And if you have any questions, please reach out and contact me for any advice you may have. And then like I said, I'll share the slides so you will be able to see the deadlines and the meeting dates for the 2024 this year. What is unique about the Research Ethics Committee, Social Sciences and Behavioral Sciences is that when you submit your application, it doesn't go directly to the REC SPE. We have department ethics screening committees and faculty ethics screening committees. So I think what confuses many of our previous applicants is that they assume when they click submit on their application, it goes straight to our office. So planning is essential. We have a list of department ethics screening committee contacts on our website, but the workflow is that your application is first submitted to your department and reviewed by your department before it is sent to the Central Research Ethics Committee, SPE. And I think we also have, I saw a question there by Prof. I can't see the specific name now, but we do have research ethics training resources available that I will try and share via Whitney. I'll just collate it with my colleagues and we'll share a slide on that with all of you. And then if you need to reach out to the REC SPE, please contact me. I am the coordinator, Clarissa Robertson. So you can contact me for any consultations or questions you might have. And then we also have a research ethics help desk officer, Mr. Aidan Williams, who can assist you with general and technical questions. So that is very rushed. I think it's 2 o'clock and I apologize that we've run out of time for questions and discussions, but perhaps for those who have very burning questions to discuss, we could have a minute or two to facilitate that. I just wanted to check with Prof Hansen if he is still online. We had a question from Vanessa who asked about what the SUREC stance is about destroying oral history data after 5 years. So I think I already gave Vanessa the information about Stellenbosch University's new research data management policies or regulations rather. Prof Hansen, would you like to comment on that?
Yes, thank you. Thank you, Clarissa. You're completely correct. It is not that we require it to be destroyed, but we suggest that all data actually it should be kept for 5 years following the end of the research project. The reason for this is that within the next 5 years, it might be necessary for you to revisit that raw data. It might be that you are questioned about it. So we always say, please at least keep it for 5 years in a safe space. And then we also understand that some of the research that you do, especially with oral data, that these are very valuable, and you do not want to lose it. And it might be, for archival reasons or whatever, might be useful in future. As Clarissa said, it's fine to then keep it. Just be reminded that if it is going to be stored in an archive or other researchers will get access to it, that the participants need to be informed about that they know about this, or that the information at least should be de-identified, so that it can be stored or accessed in an appropriate way. But that's it.
Thank you, Len. Vanessa, I hope, I'm not sure if you've left already, but I hope that answered your question. But if you have specific concerns about data retention for oral histories and you just want to check in with us, please reach out to us. Our information will be shared in the slides. It would be great to have a chat with you and get a bit more context on your needs. And then Prof, I hope I am pronouncing your name correctly, but Kuya Vanyemi asked about training in protection of human subject participants, that it's required by many funders, and which training courses are approved by Stellenbosch University. I think I wonder whether our Health Research Ethics Committee colleagues, whether you have any specific requirements. I know there's the good clinical practice. I just wanted to check in with you on the correct information there. Blanche, please go ahead.
Yeah, this is a new requirement that we are becoming aware of in terms of the NIH, and some proof that there's been ethics training that the researchers have actually participated in. So there's two sides to this coin. The one is that if you have ever done any sort of clinical ethics and so on, you can actually use that as proof. However, like Clarissa was referring to, the SIGCP is a requirement if you're doing any clinical research as well. And there are some really good online courses, as well as the more formal courses if you are going to be involved in clinical trials. There are also other resources that we can make you aware of from TREE. And so if you would like to just drop me an email, I can actually then respond to you directly, Prof.
Thank you, Blanche. I think I also wanted to mention TREE as something that from the REC SPE side is one of the training modules or resources that we recommend. I hope I'm not speaking out of turn, but I also just wanted to mention to the colleagues that the Office of Research Integrity and Ethics within the DRD, we are in the planning phases of developing a research ethics training package for our staff and students. Of course, this is in the planning stage, so it's long off before we have it ready to go and that you can engage with it. But it is indeed something that we've noted, the need for training and the need for certified training for our staff and students as requested by funders. Thank you, Prof van der Merwe and Dr. Debbie Marais for also including the links to some of the training courses available. Colleagues, I think those were all of the questions that I saw in the chat. I just want to give an opportunity to those who perhaps were waiting to the discussion session to present their questions live. If you want to raise your question now, please just use the raise hand function, and then we can give you an opportunity to ask your question live while we still have some time left. I take the silence as that it was an informative. Thank you, Hilda. It was an informative session. Colleagues, as you saw, you know our faces, you know who we are. So please, if you have any questions, if you need a consultation, please reach out. I like what Dr. Blanche Pretorius said. There's people behind the process, and we are happy to engage with you on any questions or concerns you might have.